Good morning. So, this is just a little YouTube clip which I'm putting up, having had a wonderful conversation on the Dr. Bri podcast. And it was all about episiotomies and gait, episiotomies and movement in general. And I'm just going to give you a snippet of the assessment that I use, essentially looking at the pelvis down to the foot and up, but with a bit more of a lens around the pelvis. And then a few things you can try just to see if your episiotomy scars, C-section scars, any kind of injury which you have a suspicion might be feeding into a movement pattern, a little way to get an idea if perhaps it really is a player in there. So what I will do is I'll just drop the camera a little bit and welcome to my treatment room, stroke training room. And this is how I would start to assess a pelvis online or in person. So a great thing for you to be able to explore for yourself. So to start with, just stand with your feet comfortably underneath you. And don't change anything to start with, just wherever your normal is. And we're going to just dial in with the foot pressures underneath. And sometimes if you close your eyes, it can take out a bit of the noise around you and you can actually dial back into that felt sense. So if you wish to, with your eyes closed, just notice your feet. And I want you to become aware of where you hold your weight. Is it more in one leg or more in the other leg? Or does it feel kind of symmetrical? And even though you can keep weight in both legs, you can keep it in different parts of the feet. So just notice whether you keep on your left leg your weight more at the front of the foot or at the back of the foot, nearer the heel or nearer where the toes meet the floor. And then you're going to do the same on the other leg. Is it more in the heel or is it more in the front of the foot? And they can both be the same or they can be different, which normally means there's a bit of a twist in the pelvis, which might be from an episiotomy scar, we don't know, but we'll revisit it later. Then from there, just notice whether the weight's more on the outside of the feet, more on the inside of the feet, or maybe there's one of one and one of the other. Again, and what that normally means is that the weight has shifted to one side. Again, is it because we can't move out of that episiotomy scar as we walk, as we move, as we dance and play? So once we've dialed in with those feet there, we're going to zoom up towards the pelvis. And like I say, this is a whistle-stop tour of an assessment, but it gives you some pretty juicy bits to play with. So to begin with, I'm just going to look at how your pelvis moves from left to right. And just imagine here that your pelvis is kind of like a car on a hill. And you take the brake off, and that car, like a typewriter, just starts to glide off. As it glides off, if you can see yourself on camera, just allow your head to stay where it is. We're not trying to force movement here, we're just naturally letting gravity kind of collapse us over that way. And I just want you to dial in maybe with length under the inside thigh or length around the outside thigh there on the opposite side. And then we're just going to change it to the other side. Does it feel as easy, as difficult? Does your weight actually shift across? Or do you kind of keep your weight in that other foot and just move your body? Or can that pelvis glide across to leave your body behind? The other thing which is quite interesting in this is what your pelvis does this way, as in tilting forwards and backwards. We call that an anterior tilt and a posterior tilt. And a lot of time with episiotomies, and sometimes if you take your legs a little wider, we can just pre-tension the tissue here a little more. And what I find is people glide across one way, they tilt their pelvis to make it look like they get more motion. So you can place your hands on your pelvis and just notice if anything else comes into play. Does it start to rotate? Does it start to tilt backwards and forwards? And just notice which feels easier, which feels perhaps a little more difficult or even painful. But don't go into pain, just register it, nudge it and go, okay, I'm not going to go there for now, but we'll use it later as a reassessment. So from there, we've done our side to side, we call this a shift pattern. So we're lengthening the fascia, coming all the way up the inside thighs into the pelvic floor, all the way up through the diaphragm into the neck and jaw. So from there, we're going to look at rotation. I quite like rotation as assessment. And again, we're going to look mainly at how this moves down to your feet. Not so interested about here up, just for the time being, for no other reason that we're going to keep this as simple as possible. So to begin with, imagine you have, I don't know, a laser beam on your pelvis. In front of you is 12 o'clock, and then we can go around to 9 o'clock, or we can go around towards 3 o'clock. And you're not going to get to 9 or 3 unless something cheats, or you're just the most incredibly flexible being in the world. But to start with, you're going to take that dial and you're just going to rotate it towards 9 o'clock. So I get to maybe 10. And as you go, just notice range of motion. That's the first one. And then we're going to notice whether we actually allow weights to shift into my left leg, my supporting leg, or whether I try and keep it back this way. We should be allowed to rotate into it. Then we're going to notice the foot. And you might not be able to see there, but my foot just starts to lift. The arch comes up on the left as I rotate to the left. And it kind of flattens down a bit on my right one as I rotate to the right. But both of them, the big toes and the little toes, stay in contact with the floor. The pressure slightly changes, but definitely they don't capsize like this. There is still that light contact there. Then you're going to go to the other side. Again, do I allow the weight to go into that leg? Do I feel the movement in the feet? What's the range of motion like? Is there any discomfort? Again, if you get sacroiliac joint pain, and you come to this point and you go, I've got nothing left in this hip because fascially it's all tight from perhaps, again, episiotomy scars. You go, but I want to make it look like I can get as far as this one. Then the sacroiliac joints start to take the pressure. The lower back starts to take the pressure. Or if we go down the joints, down into the knee starts to take the pressure. So go gently. Go really, really gently. So that's rotation that we've looked at there. The other things that we can look at are, how does it feel to take a step forwards? So, for instance, I'm going to turn sideways for this. I can take a step forwards on my right leg, my left knee stays straight, and at a certain point my heel starts to lift up, my weight transfers into the front leg. And I step forwards on the other leg, does it feel the same? Do I leave my bottom behind to make it look better? Do I keep my weight back so I don't put weight into the front leg? It just gives us information, this. Does it feel like a nice, smooth, elastic step forwards? Do I need to bend my knee? If I bend that back knee, then all of a sudden I've got no stretch in my hip. If I straighten the knee, I extend my hip. But if this is really tight and I extend my knee, I can just extend my back to make it look like I'm extending my hips. So there's so many little nuggets to play with in there. So just have a little play, see what you find, stay out of discomfort for me. Now, having made a mental note of all of that, we're going to come back and we are going to create a feeling of safety for your nervous system around the scar tissue. So we have three options. One is to compress the area, and that's going to reduce nociceptive input from the receptors coming up, which in English means that just for a period of time, if there is an injury where initially you felt maybe discomfort and you moved away from that place, a bit like if you step on something sharp, you move everything away from that. Just for a moment, it's going to help reduce that input. It's a bit like when you whack yourself, you go, oh my word, that hurt. You give it a rub, you compress the area. So already, subconsciously, you're working with your nervous system, which is brilliant. So, imagine it's the episiotomy scar, and imagine, I don't know, that I struggled with that movement when I shifted across this way. So what I'm going to do, I'm going to take my hand, I'm going to place it on the scar tissue. You can do it through your clothing. Just compress the area for a moment, and take your hand off, and reassess it. Does it feel nicer? Possibly, does it feel worse, or does it make no difference at all? We're just trying to build a picture here. What's important in terms of this movement pattern? Second one, for scar tissue. As scar tissue heals, it doesn't necessarily want to stretch massively because it's healing tissue. We do need to put load into there. We do need to encourage it to stretch. But when it's acute, the nervous system sets up this kind of hypersensitivity to stretch. If you've got a C-section scar, you probably don't want to come out and do that straight away. So it kind of makes sense. So to reduce that input just for a moment, we can stroke the area. So it's a lot lighter. It's not the compression, but just a gentle stroke. So the same thing, stroke the scar tissue, come back in, reassess your movement. Has it changed? Again, just information. You can do this with the C-section scar. You can do it with your appendix. Get the right side, your appendix scar. You can do it with anything at all, a broken bone, an ankle sprain, I don't know, TMJ you've had, wisdom tooth removed. Go in, put some pressure in, and just see if it changes some movement in your body, whatever you found to be stiff. The other thing you can do is just place one hand lightly over there and keep it there, which is kind of cool, but the downside of that one is that I've changed the mechanics feeding into it. So I've taken out my right arm. And if my right arm was the issue, then it's going to have changed everything coming through and give me a bit of a false negative. But this is just a way that I like to get an idea of what's playing. So if someone comes in with neck pain, for instance, so pelvis kind of makes sense, it's pretty close to the trauma. But neck pain, if that tear is fascially pulling down, and then it's dragging down on your shoulder like this, and you've got this kind of pull into your neck, which means that every time you try and rotate your head, it feels stiff. And you go, I wonder if that's my episiotomy. So the same thing. Come in, press into the area, and for this one you might be able to hold on to it a little bit and just reassess. Does it change anything? And we're not looking for perfection, we're just looking for, I don't know, a change in that movement quality, which gives us somewhere to start working from. So I hope that was useful. Feel free to get in contact if you've got any questions, but enjoy, like I said on the podcast, enjoy playing with yourself in the nicest possible way, and just be curious about what comes up, because it's fascinating to see bits which perhaps you've forgotten about, which you didn't even realise could be an issue. Maybe are playing into some patterns in your movements. So enjoy, and I look forward to it.